Good morning, everyone. I'd like to welcome everyone to our grand rounds today, especially Dorothy Weinstein, who is endowing professorship today for Dr. Jaafar, who is our grand round speaker. For many of you, Dr. Jaafar needs no introduction as the division chief for our pediatric ophthalmology division, professor of pediatrics and ophthalmology at George Washington University. But I learned a few things reading his bio that I'd like to share with you. Dr. Jaafar was born and raised in Beirut, Lebanon, attending and graduating from the American University of Beirut for undergraduate and medical school. He also completed a general ophthalmology residency at the American University of Beirut before traveling to the U.S. to complete pediatric ophthalmology clinical training at both Boston Children's and at Texas Children's within the Baylor system. He then completed a second residency in ophthalmology, coming to D.C. for the first time at the Washington Hospital Center. He then returned to the Middle East, where he started the first pediatric ophthalmology program in Riyadh, Saudi Arabia. 3 years later, we attracted him back to Washington, D.C., where he came permanently to Children's National, and in 1986 joined the division here. In 1995, he was named the division chief and was also the fellowship director for our pediatric ophthalmology fellowship program. Dr. Jaafar is a diplomat of the American Board of Ophthalmology. He is a member of the American College of Surgeons, the American College of Ophthalmology, the American Academy of Pediatrics, and numerous other national and international associations. He also gives freely of his time to numerous foundations. He's on the board of directors of the American Association of Pediatric Ophthalmology and Strabismus. He is on the Child Eye Foundation, as well as numerous other foundations. He is on the editorial board of just about every pediatric ophthalmology journal, and he has won numerous awards over his prestigious career, including the Alpha Omega Alpha Medical Honor Society induction. He received the Senior Outstanding Achievement Award from the American Academy of Ophthalmology, the American Association of Pediatric Ophthalmology and Strabismus, as well as the Sauber Award for Medical Excellence, 3 Golden Apple Awards for his excellence in teaching along the way, and because of his dedication to teaching, he had a professorship named in his honor, a visiting professorship this past year. And Dr. Jaafar's clinical acumen is world-renowned. He's a member and on the list of just about every top doctor's list in the nation, as well as here in the Washingtonian magazine. Academically, he has authored numerous journal articles on different scientific topics in pediatric ophthalmology, as well as giving scores of presentations at national and international meetings on topics such as glaucoma, strabismus, and ocular tumors. So I welcome Dr. Jaafar to open our eyes to what we should know about pediatric ophthalmology screening.
Thank you very, very much, Mary, first for the invitation, and thank you for this introduction. You didn't only remember my bio, but you embellished it so well, so thank you so much. Thanks again, Rachel and Marian, for all the arrangements and helping out. And advance, please. I have no conflict of interest in this talk, but let me start by what happened around 100 days here in the same auditorium. It was a glorious day. The Weinstein family had endowed a chair in ophthalmology, which is the very first in Washington, D.C. And this is really unbelievable because the Weinsteins have been very generous financially, but also with their time to promote eye care of children. And Dorothy, who is here with us, thank you for being here, Dorothy, representing the family. Dorothy, who is with us, is also volunteer on many boards that have to do with children and eye diseases. As you can see from the left to right is our President and CEO, Dr. Newman, then Dorothy Weinstein. Mark is their son, who is now a thriving freshman at Vanderbilt. Jay, who is not only the father of Mark and Kara, but also a very good friend. And they really, Dorothy and Jay, have been extremely supportive of our department and of eye care in Washington, D.C. Missing from this picture is Kara, who had just flown to Thailand to teach English in the Northern Territory, which just shows how dedicated the Weinsteins are to the good of people all around. I mean, it's unbelievable teaching Thai children English, how much opening of the horizon that will constitute. So Dorothy, thank you again for your generosity. In my few remarks 100 days ago, I said that this professorship, among other things, will help us keep the advocacy for pediatric eye care and keep the eye health at the forefront, both nationally and internationally. And this lecture today is one of those things. This is not the bad thing, so thanks again. The objectives of this lecture are several. One is to identify diseases where an ophthalmology consultation can really help the pediatric colleagues in finding a diagnosis and fashioning a good management plan. It is to recognize the importance of vision screening in toddlers and children. And 3 is to identify the age-appropriate vision screening tools, the validated screening instruments, the logistics and financial implications on everybody's practice. So it has both a theoretical as well as a practical component. Let me start with essentially a show and tell overview of where we are in ophthalmology and in pediatrics care. We are consulted on patients who are suspected to have neurofibromatosis, and we look for leash nodule or Sakurai leash nodules, which are just a flag. This is one of the criteria to diagnose neurofibromatosis, and we can see it here on a blue-green iris, all those brown deposits, which are small tumors, or the tan-colored changes that we see here on this brown iris. But most importantly, we are consulted on patients where we see this posterior capsular cataract in patients with neurofibromatosis type 2, which of course is much more serious. It is associated with acoustic neuromas, schwannomas, meningiomas, and the others, and the prognosis is not as good as with NF1. Back to NF1, we see the patients with those bag of worm, really bag of worm. When you touch them and you palpate them, you can feel things crawling under your fingers, which sometimes are so devastating because they obstruct the visual axis, and of course, cosmetically, they're not good. Some of these patients are also presenting with glaucoma, as we see in here. The lid is thickened, it has an S shape or an undulated shape, and all these things are important for us ophthalmologists to pick up as soon as we think of a patient with neurofibromatosis. Actually, this child we were consulted upon, and I did ask the mother if she would undress her child, and believe it or not, we saw the cafe au lait spots, and we refer the patient. So it's a back and forth kind of a relationship with you, our pediatric colleagues. Again, back to neurofibromatosis, it is associated with optic nerve gliomas, and these patients, we really follow them with ocular coherence tomography, visual fields, looking at their optic nerve and see if there is any advancement, any affection of the vision, which will direct our neurology and neuro-oncology colleagues for treatment or not on these patients. Sturge-Weber syndrome is another phakomatosis, and again, this is a child who has bilateral disease, more so on the right than left. 50% of these patients with these nevus flammeus have glaucoma, which again is a blinding disease unless it is detected and treated early. Moving along, in our armamentarium and how we can help each other diagnose, we have this patient with Alport syndrome. I really don't know if you can see it from here, but these patients have what we call an anterior nipple here in the lens. which is pathognomonic of Alport syndrome. Patients with an oil droplet lens opacity, and patients with galactosemia, microspherophakia, and an Ehlers-Danlos syndrome child, and last but not least, ectopia lentis in patients with Marfan's, homocystinuria, and the others. So it's not only helping the diagnosis, but also in the management of these patients. A 1-month-old girl with infantile spasm, abscess of the corpus callosum, and those lacunae by the optic nerve here and inferior to the optic nerve there, and another patient, those lacunae in there. And this makes the diagnosis of Aicardi syndrome, which is one of the rare dominant X-linked diseases. So, boys do not survive, but girls do. And again, a diagnostic importance. Optic nerve, we are consulting patients with pseudotumor cerebri. We see the swelling of the optic nerve, tortuosity of the vessels, cotton wool spots all around. And management, again, is important. Visual fields before treatment, visual fields after treatment. MRIs are helpful. They show the flattening of the posterior globe, and we can see dilatation of the optic nerve sheath. These are diagnostic issues that we look into, but not every elevation of the optic nerve is papilledema. There are patients who have prominent optic nerve that are protruding into the vitreous but do not have increased intracranial pressure. And this is an example of a patient where ultrasound did show a drusen of the optic nerve causing the elevation, but again, this rules out intracranial pressure increases and saves the patient tens of thousands of dollars of workup and agony to the family. These are usually benign. Optic nerve hypoplasia, where we have a small pale optic nerve head with a double ring sign. And what's the double ring sign? For the casual observer, this is thought to be the optic nerve, which is almost of normal size. But the optic nerve actually is only this little one at the very, very middle. It is pale, it is not functioning, and many of those patients, more than 50%, are associated with the Morsier septo-optic dysplasia syndrome, which makes an MRI, but most importantly, an endocrine workup very important. These patients have adrenal insufficiency, and if it's not diagnosed early, they can die in front of us. They have diabetes mellitus, they have many other intracranial abnormalities. So again, this is the outer ring in here is nothing except sclera, which with less pigmentation, and the optic nerve is small and down in here. We thought in the past that only patients with bilateral optic nerve hypoplasia have systemic abnormalities, but now we got to find that even patients with uniocular optic nerve hypoplasia can have intracranial abnormalities. A 15-year-old presenting with progressive external ophthalmoplegia. The lids are down, the eyes are essentially frozen. Patient is, looks essentially the same, looking straight ahead, looking up, looking right, left. The eyes don't move very much. In the workup, we look at the fundus. And in this patient, we have a pale optic nerve. We have pigmentation in the periphery. All these changes between progressive ophthalmoplegia and retinopathy would make us think of Kearns syndrome. Kearns was an ophthalmologist, there was a cardiologist, and they came up with this syndrome, which is progressive external ophthalmoplegia, pigmented retinopathy. And if we see that, we have to send this patient to our good friends in cardiology to look for conduction defects, because these patients have almost a 2/3 incidence of conduction defects, and 11% in one of the series had a sudden death. So these patients need to have an electrophysiologic cardiology workup, and some people even advise having a pacemaker prophylactically in these patients because of their conduction defects. Retinal hemorrhages are not pathognomonic of battered child syndrome or non-accidental trauma. However, they are piece of the puzzle that you put together with the history, with the physical exam of the child, with radiologic imaging to figure out if this child has non-accidental trauma or not, which of course is extremely important. It has to be reported. And the reason why we report these is we want to make sure that the child who comes to our emergency room with non-accidental trauma does not go to the same milieu where, unfortunately, many children can be abused again and come back dead to us. So this is really important for us to keep our eyes open to. Juvenile idiopathic arthritis. Our rheumatology colleagues, our pediatricians have known that these patients have to be referred and referred early for diagnosis because anterior uveitis, which is quite common in these patients, is usually asymptomatic. 10% of those patients present with uveitis first and then the arthritis, but 90% the arthritis precedes. It has a very insidious onset. It's usually bilateral but can be asymmetric. And it is truly a devastating ocular disease, potentially blinding because of the cataract and the glaucoma. So a routine examination is truly a must. We still go by Cassidy, Kaplan, and colleagues' publication in 2006, which was a consensus statement from the American Academy of Pediatrics, the American Academy of Ophthalmology, the American Association for Pediatric Ophthalmology and Strabismus. They found out that, the younger the patient is, the shorter the duration of the arthritis are very high risk factors, especially if the child has ANA positive titers. So these patients really have to be followed very closely. If you have a positive ANA, you are less than 6 years old, and you haven't been diagnosed for more than 4 years, an examination every 3 months is mandated because, again, this is a silent disease when it starts. And, you're familiar with this table, and this is a summary slide to emphasize the fact that there are risk factors. The post-articular or oligoarticular disease, ANA positive, female sex, if the child is younger than 6 years of age, and in the first 4 years of diagnosis. 11% of the total patients with arthritis have uveitis, but if you look at the patients with ANA positive titers, around 30% of them do have uveitis that has to be diagnosed and treated. This is, of course, an advanced case where we have those KPs, keratic precipitates. It's accumulation of white blood cells on the back part of the cornea, on the endothelium. Here at Children's National, a congenital Zika virus program was instituted. It's a multidisciplinary effort, and we see those patients. Luckily enough, we haven't seen any patients with eye findings yet, but these are some slides from our colleagues in Salvador, Brazil, Fuentes, and Belfort. And we can see mottling of the retina in here. We can see this whitish hypopigmented lesion in the macular area. In other patients supratemporally, we have this coloboma-like lesions and mottling of the retina. Enlarged cupping of the optic nerve. Again, the lesions in the periphery. And many a time, we can also see those colobomas in this patient, which are central. Colobomas are absence of the choroid. They're usually, if they are congenital and not associated with other disease, are usually inferior. These are nasal. And this patient specifically has also small optic nerve head, as you can see here. This is the very, very tiny optic nerve head in here. So multiple ophthalmic findings can be seen in these patients. And we help our friends in ID examine those patients. I saw one of them. Luckily, she was fine yesterday. So I hope that with this quick overview, I emphasize the need for us to keep working together and figuring out how we can detect eye diseases early and how we can help you in ophthalmology make the proper diagnosis early. In this way, we can prevent devastating issues like in patients with the Morseau syndrome. Going to shift gears and go to a simple screening can save a sight. For those of you who are in public policy, I'm sure you've read the 700 or 800-page report that just came from the Institute of Medicine that is now called the National Academies of Sciences, Engineering, and Medicine. So they not only have changed their name to a mouthful new name, but look at this statement, which is really very important to see. This is at the forefront of new policy. I have to read it because it's complicated. It says, ensuring that people receive proper visual acuity screening and preventive eye care services and adhere to effective eye protection practices would eliminate thousands of preventable or correctable cases of vision impairment that result each year from amblyopia and eye injury. And that's really very true. Failure of the United States to address these sources of preventable suffering and disparity is simply not acceptable. So this is a new push. It is just September last month that this was published, and hopefully it will have its impact as other statements from the Institute of Medicine had in the past. So what's the difference between ophthalmologist and a pediatric ophthalmologist? Yes, we deal with small people. Yes, we deal with small eyes, but it's not only that. Most importantly, we have amblyopia, lazy eye. Amblyopia starts in children, has to be detected early and treated early, otherwise we're not going to be successful. Along with that, we look and make sure that the patient has binocularity by straightening their eyes. And with good vision and good binocularity, these patients will have depth perception, 3D vision, and will have a beautiful life. So this is really what the difference between pediatric ophthalmology and adult ophthalmology. If you want to have one word, it is amblyopia. What's amblyopia? It is a decrease in vision development that happens when the brain does not receive normal stimulation from one or both eyes in childhood. Okay? So it is a vision impairment that is at the brain level. If the brain is not receiving a clear image consistently from each eye, the brain is not going to learn how to see. And this is what we're going to make sure that we teach the brain how to see by detecting amblyopia early. Abnormal development of vision leads to permanent loss of vision if not detected and corrected early. What's another definition? What's a practical definition of amblyopia? It's reduced central vision. Patient has 20/60, 2200 vision, but by examination of the eye, there is really nothing that explains it. You know, the patient may need glasses, you give them glasses, the vision still not improved. The patient has cataracts, the cataracts off, you put a contact lens, and the vision still not improved. So the eye is good, should be able to see, but is not able to see because the vision, the brain is not seeing. And the pathophysiology is anything that is listed in here. Any media opacity, be it a corneal opacity, a cataract, vitreous hemorrhage, strabismus, which we are very familiar with, causing amblyopia, or as we call it, you know, many people, lay people say lazy eye is strabismus, which is not. And severe emmetropia, severe refractive error. This is a few slides that show a patient with strabismus, a patient with severe ptosis covering the visual axis, a patient with unilateral cataract, and a patient with a corneal opacity secondary to glaucoma. If a medial opacity, like in cataract, is bilateral, or the corneal scarring is bilateral, patients will have bilateral amblyopia. And this is something that many a time when we hear about it, we don't connect because we think of amblyopia always as unilateral. And this is a schematic description of when we have amblyopia and other times when the eyes look straight, everything looks good, but the patient is not seeing. A patient with unilateral myopia, the image is very nicely focused on the retina of the left eye, but it is focused in front of the retina in this other eye, in the right eye. So the image on the retina is blurred. The brain doesn't like that. The vision is going to be decreased. We have amblyopia in the right eye. Same thing with hyperopia. The image is focused behind the eye. The retinal image is blurry, amblyopia. Patients with cataract, we don't have a well-formed image. Same thing. Take the lens out for cataract, but do not replace the lens with a contact lens or intraocular lens. The child still cannot see, so our work is not done. And the patients with high refractive error. So many a time, child looks fine, behaving very well visually with both eyes open, but when we cover one eye, we recognize that vision in the other eye is not good. Why is it important to screen for amblyopia? It affects 2 to 3% of the population. It's usually preventable, usually unilateral, but can be bilateral. Early detection is key to effective treatment. Treatment depends on the plasticity of the visual system, so early does it. Life-threatening conditions may present as poor vision, retinoblastoma, optic nerve hypoplasia, retinal dystrophy. So these are important things for us to detect early, again, to make the diagnosis and the proper management. And it is recommended as part of the American Academy of Pediatrics Bright Future Periodicity Schedule. 2 to 3% incidence means we have 100,000 new cases a year in the United States alone. Prevalence is 12 million amblyopes. Half of them have vision of less than 20/80, which is not good vision for anything in life. And to bring the message home, a study that was done in Australia years ago and has been duplicated by many other authors show that people with amblyopia have almost 3 times the risk of visual impairment in their better good eye with significant decrease in vision. So it is not, yes, it's nice to have 2 eyes seeing, it's nice to have 3D, but for practical purposes of these children lose the good eye, it's a catastrophe. Well, there are barriers to screening, and we have been pushing for screening in the medical home, in the pediatrician's office, in the family physician's offices, but we have barriers. Poor cooperation of young children, it takes time to perform, staff is not adequately trained, and there was poor reimbursement for physicians. So ophthalmologists with pediatricians have been working on decreasing those barriers and removing them. And we have come up with visual acuity screening guidelines, which are age-dependent. So below age 3 years, the pediatricians do a vision screening as in the neonatal care unit. Take a history of eye health, is there prematurity, the child has any syndromes, if there is any eye problems in close relatives like pediatric cataract, pediatric glaucoma, and we check the vision tracking, make sure that the eyes move well, that the patient does not have nystagmus, and the eyes are straight. Corneal reflexes should be centered, as we can see in here, and of course we check the pupils and the red reflexes. This is a summary of the guidelines, and the younger the child, the more lenient we are. The older, the more strict, with the better vision acuity we want them to do. So if the patient is 3 to 4 years of age, they should be able to see most of the optotypes, most of the characters on the 20/50 line. If they are between 48 and 60 months, 4 to 5 years of age, 20/40, if they are above 5 years, they should be able to see the 20/30 or 20/32. And of course, we check each eye on its own. And after age 5, the patient, if they pass, they should be seen every 1 to 2 years. Patients who fail these vision screenings should be referred to either a pediatric ophthalmologist, general ophthalmologist, or comprehensive ophthalmologist in the community to figure out what's going on. These are good ways of checking vision 1 eye at a time. This is a very bad way because children, believe it or not, are smarter than we are. And children would want to perform, so they're going to be peeking between the frame of the glasses and that little cover that looks cute, but it doesn't do the job. This is semi-good if it is held well. And if we drop that pinhole in front of the vision, if this child doesn't see very well, she sees 20/200, but we drop this cover in here and she sees through the pinhole and the vision improved from 20/200 to 20/40, 20/30, we know that this child most probably has a refractive error. It's not that scary. The patient needs the glasses, needs an examination, but it is not the referral where the ophthalmologist needs to see the patient next day. We have moved to slides, vision slides that look like this, in this V shape, and there are different ways that we can check that. The LEA symbols have been validated, and we can see in here that the difference between the space between each line and each character is essentially standardized, and this is why these are much better than before. So we have the LEA symbols, of course we have the letters, and HOTB, just 4 letters. And these cards come with a small card that the patient can hold, and they can match the O on the screen with the O in their hand or the parent's hand. It can be done. We have been able to get vision in these with the HOTV as early as 2.5 years of age in smart kids like my grandchildren. But you know, LEAs are really good, and we start with the bigger ones that every child sees, and we can move along and eye by eye. These are not any longer recommended. These are the old charts, even in the veterinary office checking the dog's vision. We use now the Sloan chart. It is not as good as before. And this chart is not recommended at all for any children. Again, to make it easy, because the pediatricians are busy, and the children are bombarded by so many different things. So we have, to make this even easier for screening, we have two types of charts. We have ones with a threshold line. If the child can read this, we stop and say, goodbye, you are good. We have one column for the right eye, one column for the left eye. But if the child is cooperative and it's not taking a lot of time, we ask them to read as much down as possible. So if they read the 20/20 line with one eye and only the 20/50 with the other eye, we know that this patient has amblyopia in the left eye. So the threshold line is really helpful. It makes the screening easier and faster. Or we can have a critical line screening. So we start with this top line, which just to make sure that the child understands the game. Okay, this is a square, a heart, a house, and circle. And once they do, we can ask them to read this line with the right eye, that line with the left eye, and if they pass, thank you very much, you're good. Next. And again, we can do the same thing with that. All these are available. Good Light, other companies sell them. AAPOS, the Pediatrics Ophthalmology Society, has come up with this screening kit. It has nice spectacles for occlusion, the lorgnette, DVDs for instructions. It has LEAs, it has HOTV, it has letters. Available, easy, you can do it, you can choose whatever you want, you can go with the threshold line, you can go with the one line. All these work, and the key is they have to be done. If we don't accept to do them, we're always going to think that this is impossible, the child is too busy running all around and we have to move in a busy clinic. These can be done, and it's interesting, you know, we have pediatric practices where we see every child who has failed, and we have never seen from these practices a child who presents late. And we have practices where we see referrals every now and then where the child comes late. You know, we barely can catch up. We can improve the vision, but not get it to 20/20. And the difference between pediatric practice 1 and 2 is that pediatric practice 1 has tried it, it worked, they keep doing it. And this brings me back to advocacy. The Children's Eye Foundation is now the catalyst or the dynamo that is keeping everybody in the vision care together. From AAPOS, the Pediatrics Ophthalmology Society, the AAP, American Academy of Ophthalmology, American Association of Certified Orthoptists, they have come together, and finally, after years of negotiation and going back and forth, they came up with a statement, and they came up with guidelines, and they came up with ways that we can do that in many fronts. And this has been published as a practical guide for primary care physicians. If you want to take this website link, children'seyefoundation.org/C, and see in here. And our mascot, new mascot, is See More. So See More is looking at us right now to make sure that we're doing the right thing. And these practical guides came in 7 pages. The page 1 and 2 are an introduction to let the pediatricians know what's going on, why it's important to do it. 3 to 6 is how to do it, and 7 is a sheet that we give to the parents to let them know. I mean, the pediatricians or the school will give it to the parent and say, you know, we did a vision screening on our child, and your child passed, or your child did not pass, and if they did not pass, why they did not pass. So it's really a contained thing. It's just there for everybody to do it. So what do the guidelines say? about the instrument-based screening. It is not experimental any longer. It has been validated for screening very young children to detect most common conditions that cause amblyopia, like refractive errors, like cataract, like glaucoma. The AAP and the U.S. Preventive Services Task Force recommend using it in children who are 1 to 3 years of age. Not below 1, we don't need it below 1. And in some children who are 4 to 5, who either don't want to participate in the vision screening, the chart vision screening, or unable to do that. And these devices are now available commercially, and they had extensive validation, both in the field as well as in the pediatricians' offices. So they are there for us to use. The American Academy of Pediatrics policy statement was published in Pediatrics in 2016. It says that photo screening is recommended for children 12 months of age and older unless they can reliably perform visual acuity testing with eye charts. So direct measurement of visual acuity using eye charts remains the gold standard. If we can do it at age 3, at age 2.5, at age 5, this is what we have to do. We should not do the instrument, because the instrument gets us the predisposing factor for amblyopia. It does not diagnose amblyopia by itself. But again, if the child cannot do the chart, we have the instrument screeners. So a photo screener or an autorefractor takes photographs of the image, look at the red reflex, see if there are any crescents, any whitishness, any yellowishness, and converts it mathematically into a visual acuity component. It also can detect ocular misalignments like strabismus, and or conditions degrading or blocking the visual axis like a cataract or a corneal opacity. So this is what pediatricians are asked to do. So between chart 1 on the computer and chart 2 on electronic medical record, these are the few things that you have to do. From eyes to vision to heart to abdomen to urinary tract to everything else. So let's concentrate on the eye. So this is the periodicity schedule for visual system assessment in infants and children and young adults. It is by age, newborn to 6 months, 6 months to a year, 1 to 3 years, 4 to 5, and 6 months. And every patient, we take ocular history, we look at the eye externally, red reflex testing, pupil examination, ocular motility assessment starting at age 6 months. And we see if the patient follows and face. If the patient is following the pediatrician's face. I used to have mustaches, and this was the best visual stimulation. I come into the room, the child cries, he sees. And in patients who are 1 to 3 years old, instrument-based screening is now available. Okay, we can use it up to 4 or 5, again, if the child is not cooperative. But afterwards, we really have to go with visual acuity, age-appropriate optotype. It is feasible, it's doable. Considerations. Well, the age of patient is important. The younger, the more lenient we are. The older, the more stringent. Sensitivity and specificity. There is nothing that we do in medicine except we look at those things. We cannot be too sensitive because we're going to have a lot of false positive referrals, and the families are not going to like us. Specificity is important, but we can be too specific and miss some cases. So we really have to strike the balance. And these vision screeners have gotten there. I wouldn't be able to say that a year or two ago. And again, they detect amblyopia risk factors. The younger, the more lenient we are. More than 2 diopters of astigmatism, more than 4.5 diopters of farsightedness. And as they get older, the farsightedness goes down to 3 diopters. It's metropia, difference in the refractive error between one eye and the other, only 1.5 diopters. And if the patient is myopic for more than 1.5 diopters, which affects their performance at school and being able to compete in this world that we live in. And in all ages, they detect media opacity and manifest strabismus, large angle of deviation, not small ones. Again, age dependent. These are common vision screening instruments that are available on the market. The Plus Optics the spots and the eye screen are the ones that are most used in our area. These instruments are child-friendly. They are not threatening. They are done at around 1 meter, 3.5 feet away from the child. It takes a very quick take, 1 second to 7 seconds maximum. It is done, and both eyes are examined at the same time. So it's really very quick. All what you need to do is to get the patient's attention for a few seconds, and you can get it. This table and the next one is data that has been accumulated by Jeff Corbin from Washington State, from Spokane, and it compares all the commercially available screeners. The purchase price is, of course, important. They range between $4,000 and $7,500. Some companies charge per exam. So for the eye screen, there is a $10 charge because, once the screening is done, it is sent to a centralized office that reads them and gets you the answer back the next day. Which brings me to the second chart, which is about interpretation. Most of these, you read what you see on the machine as you are doing it. On one of them, the eye screen, you have to send it to a central office, where the screening is read by experts in there, and it's very accurate, but it takes 24 hours. And the acquisition time may be a little bit longer. And last but not least, there are a couple of these screeners where you can have direct interface with the EMR. So for the pediatrician, we always say, look and see what's available. These are all good, and see what's best for your practice. So the instrument vision screening is useful for children 1 to 3 years of age. In children who are 3 to 5 that decide not to cooperate, or on older children who are nonverbal, developmentally delayed, autistic, and they're not able to do the acuity chart. What's the difference between the two? Again, the vision screening with eye charts, that's the actual visual acuity as it is, 20/20, 20/400, 20/15. The vision screening detects predisposing factors, high refractive error, difference between one eye and the other, which usually or many a time can cause amblyopia, but the machine cannot tell you if there is amblyopia or not. Well, are these reimbursable? Yes, after many, many years of lobbying, we have CPT codes. And these CPT codes can be billed separately and on top of the well-child visit. They are not bundled. 99173 is if you can do the chart vision screening. 174 is photo screening with a remote interpretation, and 177 is when you get the interpretation on the machine itself. So the codes are available. U.S. Preventive Services Task Force has recommended that this has to be done at least once between age 3 and 5. The Affordable Care Act requires that health plan covers for these without copay as preventive services that are labeled A or B rating, and vision screening is rated as B. And there may be also some tax advantages with the American Disability Act for the purchase of photo screeners. So, the cost can be recuperated through the CPT code. The cost can be, part of the cost can be recuperated through tax exemptions. Are there other vision screening devices? There are many, 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 many. The Diopters Enfant 2 is very attractive. It's like a VEP. It has been pushed very hard all over. Do not use it. And on the other hand, there are a lot of programs that are being developed. The iSpy 2020 is one of those nice computer games. The child has both eyes open. It checks the vision, checks alignment, it checks color vision, and so on and so forth. It's being refined, and in a year or two, I think we'll have more of these programs where the parents can do it at home, or where the child is sitting in the waiting room and can do them themselves. So, in summary, automated screening makes possible a future where all children get screened during their annual well visit. The result will be the early referral of more children at risk for amblyopia and strabismus. and thus a shift in the curve of care delivery to a preventative stage where diseases is manageable, affordable, and correctable. We have a deadline of 20/20, year 2020, where we're going to eradicate amblyopia in the United States, and 2030, where we're going to eradicate amblyopia worldwide. I think these are achievable. This is a tremendous progress. I acknowledge the AAPOS screening committee members that were really instrumental both on AAPOS Academy of Pediatrics and on Capitol Hill to get these approved. And my many, many thanks, number one, to the Weinstein family, and thank you for your attention. Question? Yes, sir. Dr. Teach.
Jaafar, that was amazing. Thank you very much for that. Can you remind us about vision screening in the first 12 months of life? None of the recommendations really included that, and I just wanted to be reminded as to why and the limitations or barriers in that age group.
The only thing that is not recommended is instrument vision screening, because number one, it is not always correct, and number two, even if we have referrals of a child who is 9 months old with significant astigmatism in one eye or both eyes, we are still not going to intervene because the child doesn't sit well enough to wear the glasses and use them properly. And also we have found out, especially with the British literature, that if we postpone our management a little bit, it is not detrimental. So we can still catch these patients early on. Having said that, we still depend on the pediatricians to do the red reflex, the fixation and following. We, believe it or not, ophthalmologists take history. So we believe in the fact that if the parents tell, my child doesn't see, you know, we have to listen and figure out why don't they see. So we still have some vision screening between birth and age 1, but it is not the vision screening by instrument or chart.
Thanks again, Mohammed. I wondered if you could speak to the role of the optometrist versus the ophthalmologist in preschool vision referrals, or you know, if a pediatrician sees a child who is failing the eye exam, what is the role of the optometrist versus the ophthalmologist?
There is a definite role. There is a definite role. Again, if we feel that by history, by patient behavior, by our examination, that what the child has is probably just decreased vision due to needing glasses or something like that, the optometrists are very well equipped, very well trained to do the examination and to provide the treatment. However, if the pediatrician is really not very sure why the child doesn't see, you have a 3 years old and the child doesn't see in one eye or both eyes. These patients, we are more than happy to see because the child may not be able to see because he or she is not cooperating in the exam. They might need glasses, or they may have something that is more serious, a special type of cataract that you cannot detect by yourself, some changes in the back of the eye and the retina optic nerve and so on. So we have been seeing patients, I mean, pediatric ophthalmologists have been seeing patients who are below 8 years of age, where the detection of eye diseases is very important. If the patient passes or they just have glasses or something like this, we discharge them back to the optometrists and the ophthalmologists in the community. So there is definitely room for our cooperation and so on. I know that this is being recorded. So one caveat, and this is something that, you know, we are kind of chastised about it, is that unfortunately in every community there are optometrists who are a little bit too pushy, too aggressive. Any child going in their offices is going to have a recommendation for vision therapy. And this is a problem that we have, but we don't want to punish the children, but not by not sending them to the optometrist for early examination, or punish all the optometrists who are really good because of our fear of vision screening recommendations by some developmental optometrists.
Thank you very much. This is really useful. My question relates to your comment on the coloboma found in Zika virus and comparing that to congenital colobomas. Are there other congenital viral infections that lead to coloboma, and is it possible that some of the, in quotes, congenital coloboma might actually be residual from congenital viral infections?
The pictures that I showed are really very typical of colobomas, except that, you know, the congenital colobomas are usually inferior. Not really. I mean, toxoplasmosis can have a lot of hypopigmentation with surrounded hyperpigmentation and so on, but they usually have some other features with them. Lymphocytic virus can have some optic nerve, but also some retinal changes, but they don't look like colobomas. So, as far as I can tell, this is really the very first one that we see. Have we met some Zika or Zika-like viruses that cause those colobomas? Possible. But so far, none of those colobomas in Zika have been described inferiorly. We have a question from online.
As far as you know, are there any concerns regarding breach of protected health information with electronic transfer of results for interpretation from primary care office to eye screening entities?
The question is there any breach of confidentiality by sending the information to the eye screen or any other company back and forth? These are protected with HIPAA protection measures. So, like anything that we share on the internet, there's always some hacking going on or possibly going on, but you know, I mean, the companies are trying to protect for that as much as possible. So they are supposed to be secure correspondence back and forth. Well, thank you again. You know, on the first day after the Academy of Pediatrics, we had a good turnout, and thank you for your attention. Thank you very much for the invitation.